The next talk is about gut motility and patient wellness, optimizing care strategies. As you all know, abdomen is surgeon's kingdom. As a surgeon, I have the privilege of introducing an eminent person who has done many researches about the diseases of that kingdom. Professor Shaman Rajindrajith is the chair professor of pediatrics in the University of Colombo. He serves as the consultant pediatrician with special interest to gastroenterology and hepatology in the Lady Ridgeway Hospital, Colombo. Previously, he was the head and professor in the Department of Pediatrics, University of Colombo, and he was president of Sri Lanka College of Pediatricians in the year 2021-22. I'm going to give you the summary of his CV because it's too extensive. He has published many scientific papers in international journals. His research interests include epidemiology and pathophysiology of functional gastrointestinal disorders, infectious and inflammatory bowel diseases. He has delivered many lectures on a variety of topics on gastroenterology, both nationally and internationally. He has received many presidential awards for research in Sri Lanka and has obtained the CVCD award for the best senior researcher in the year 2023. He serves as editorial board member in several international and national pediatric journals, and he is a member of Rome 5 Committee for Disorders of Gut-Brain Interactions. Now, may I invite Professor Shaman Rajindrajith for the talk about gut motility and patient wellness, optimizing care strategies. Over to you, sir.
Good morning, ladies and gentlemen. Thank you, Rajendra, for that kind introduction. And I'm very grateful to the organizing committee of this conference for inviting me to deliver this lecture. So, this is gut motility and patient wellness, optimizing care strategies. Human intestine is a fascinating organ, ladies and gentlemen. It does quite a lot of functions to sustain life. But the main important thing is to digestion of food and absorption of water, nutrients, minerals, and vitamins to sustain the life and store the waste product in the intestine to expel it when socially acceptable. So to do these fascinating functions, the human gut is equipped with enteric nervous system, enteric immune system, enteric endocrine system, and of course with the gut microbiome. So I will focus few slides on enteric nervous system. Enteric nervous system has two parts, submucous plexus and myenteric plexus. So this is submucous plexus, which is just beneath the submucosa, and the myenteric plexus is between the circular and longitudinal muscles of the intestine, which is absolutely important for the motility. So myenteric plexus is well connected with the submucous plexus as well as with the outside through the brain-gut axis, sympathetic, parasympathetic, and sensory systems. This drives the whole thing about motility of the intestine. So this complex system, very fascinatingly, derived of three main motility patterns of the human intestine. So the peristalsis and segmentation are postprandial. You can see the slide in this corner has the peristaltic movement, to and fro movement, and in the jejunum you can see to and fro movement of segmentation where food is digested and absorbed, and the migratory motor complexes occur in fasting states. So where you see a mass movement of intestinal contents from proximal to distal. So these are the three main motility patterns. To regulate these motility patterns, there's an extensively complicated system. Let me make it pretty simple, right? So the myoelectrical activity of the gastrointestinal tract is the main driving force. So where does it come from? Mainly interstitial cell of Cahal. That's the regulatory cell that regulates slow waves and peristalsis as well as relaxations. So then enteric nervous system, autonomic nervous system and central nervous system has their own parts to play. And there are neurotransmitters which you all know. So there are inhibitory neurotransmitters which are VIP and nitric oxide, and there are excitatory neurotransmitters like acetylcholine and substance P. And there are gastrointestinal hormones like motility and gastrin which augment peristalsis, as well as somatostatin which can reduce peristalsis. And there's central nervous system hypothalamo-adrenal axis that leads to control with gastrointestinal motility with hormones, and then you have mast cells which produce histamine that control the gastrointestinal motility up to a certain extent. So, and then we have our microbiome which has a major influence on motility. So these are the regulatory systems of the gastrointestinal motility. Now, when the motility patterns are deranged, motility disorders and disorders of gut-brain axis starts to emerge. So, these are the disorders of gut-brain axis which are going to be my major part of the talk in the second stages. So there are a lot of, you have seen, most of you have seen this, and people coming with dyspepsia, IBS, constipation, aerophagics, and when Rajendra would agree with me, abdominal pain is one of the commonest presentation for children to surgical wards even, right, and fecal incontinence, all that. So these are disorders of gut-brain axis. Actually, ROM4 have derived very clear classification for neonate and toddlers and children and adolescents, which are published in 2016. Now we are updating it in 2016. We are working on this area quite extensively, reviewing the literature at the moment. So the final papers and the books will appear in 2026. There is another severe motility disorders which are due to what Anuja talked a few minutes ago about something to do with stem cells. So they are more severe pediatric motility disorders, including achalasia, pseudo-obstruction, gastroparesis, Hirschsprung disease, like that. So my talk would be mainly focused on DGIBs rather than severe motility disorders. They are very complicated matters. So, prevalence, let's see how prevalent is functional abdominal pain. Roughly 13.5% of children globally are suffering from abdominal pain, and Sri Lanka the number is somewhere around 12.5%. We are updating this systematic review, and it will be probably published in very early 2025. We found the estimate is somewhere around 12.5 with new evidence, because we don't have any prevalence studies from Africa. So we found some African studies. So it's going to be slightly lower, but not statistically significantly different. So it's somewhere around 10 to 13%. And look at the functional constipation. Global prevalence is 9.5%, and our prevalence in Sri Lanka is somewhere around 15.4%. And this is prevalence of aerophagia. Global prevalence is about 3.6. In Sri Lanka, it is about 7.5. So you can see we have a fair share of our problems with functional GI disorders. So what happened to the well-being of children when we have functional GI disorders? I will show you a few things about it. So the first thing is quality of life. Quality of life, ladies and gentlemen, is very important to measure the effects of a disease where there is no precise biomarkers. Now, we don't have precise biomarkers for functional GI disorders. So we have the basic quality of life studies. So this systematic review we conducted found, you can see the whole global available studies globally shows very poor quality of life of children with functional constipation. Now, this is few Sri Lankan studies we conducted. So the quality of life is measured as physical functioning, emotional functioning, social functioning, and school functioning. You can see all down when compared to controls in functional GI disorders, which are abdominal pain predominant functional GI disorder. You know that IBS, dyspepsia, migraine, and functional abdominal pain. So this was aerophagia. People don't care about that much, swallowing bit of air is not going to be a major issue. That is what people think. Look at their quality of life. It's also very poor. So this affects their well-being in a reasonable way. So obviously you can understand when they have fecal incontinence, their quality of life is down. So these things affect children more than what an ordinary clinician think of. Right? So what are the psychological problems they go through, right? These are some of our research that we conducted early part. So this is about abdominal pain. Look at the emotional problems, stressful events that they go through. Very simple things become emotional and stressful to these children. Separation from best friend, death of a family member, loss of parents' job. These minor things sometimes can affect them very badly. Right. So childhood constipation and exposure to stress. You can see exposure home-related, school-related, and child maltreatment. All three categories affect their emotional well-being. So this is psychological maladjustment we published in Archives in 2017. So you can see most of these problems, they have, hostility, aggression, negative self-esteem, everything, which destroy their emotional well-being. Now that affects their quality of life as well negatively in return. So if you have higher emotional personality scores, you have very poor quality of life. So personality abnormalities, this is we used to check the same thing in children with abdominal pain, very similar, right? And this shows behavioral problems associated with children with constipation. You can see they are withdrawn, they are anxious and depressed, and they have internalization, all sort of problems with related. So it's not simple gut. It's beyond the gut. They affect their emotional, social well-being, actually. So motility studies that can be done to assess these things are multitude of. Right? So you can, if you suspect esophageal problems like aerophagics, we can do manometry, pH impedance, and stomach gastric emptying studies. Small bowel, you can do orocecal transit and intraduodenal manometry. Large bowel, you have a gamut of investigation that can be done. So out of this, now most of these things are very sophisticated, and systems need about 40 million to establish in a new setup. So we developed something to assess gastric emptying and intraduodenal motility. So this was, we saw this and studied this system and developed a simple way of assessing gastric motility in children. So we used a liquid meal. So we keep them fasting and measure their gastric emptying in the fasting state using a simple ultrasound through the liver and a plane which related to liver, aorta, and superior mesenteric artery. You can see the PA is pyloric antrum. So then we give the liquid meal and see how it works, right? And then what distension that it gets, how the motility patterns comes up. So then we develop three simple things like gastric emptying, amplitude of antral contraction, frequency of antral contraction, and motility index. So by using this, we assess children with functional GI disorders and publish So this is about irritable bowel syndrome, and this is about functional dyspepsia and abdominal migraine and functional abdominal pain. When we summarize all these 4 research, what you find is something very similar, right? So children with functional abdominal pain, IBS, functional dyspepsia and abdominal migraine would have poor gastric emptying and abnormal antral motility. So we can use this to create a therapeutic model for these children. So then, optimizing care, how can we optimize and how can we help these children, right? So pharmacological interventions for constipation, the best drug that have ever been developed up to now is polyethylene glycol. You can see this is a randomized controlled trial involving 103 children. They have used 0.2 gram per kg, 0.4 gram per kg, and 0.8 grams per kg, and for 2 weeks actually. You can see here, even in 2 weeks, the higher the dose, higher the response rate. This drug is called as the most potent osmotic laxative that has ever been developed, and it has free of side effects, very, very few side effects, if at all. So polyethylene glycol is one of the best that we can use to treat children with constipation. And when you compare polyethylene glycol with lactulose, there's no major difference. You can see here, but you can see in the other part, there are less abdominal pain and less pain in defecation and less straining. Then comes more scientifically, established drugs like, 5-HT agonists. So you can see cisapride, tegasertib, and flucarabide. Here we have the flucarabide trial for children. Although it works in adults very well, we didn't see any major effects in children with constipation compared to the placebo. So similarly, lubiprostone trial was completed in 2022 and didn't see any progress with regard to overall spontaneous bowel movement per week. So they are failing trials, at least considered to pediatrics. So non-pharmacological interventions, for constipation, although people think high-fiber diet, increased water intake, all these things work. Actually, in real life scenario, they are not very much helpful. The only helpful thing is toilet training. Very, very important to toilet train children as they come with constipation. Without toilet training, none of the drugs will work because they withhold stool. Stool withholding is the most crucial point in developing childhood constipation. So, abdominal pain, what can we do? So there are so many drugs that has been tried, and some of them have success stories, some have failed. So what we did was, knowing that they have poor antral motility and gastric emptying rate, we tried, one of my PhD students tried this, domperidone, something pretty simple, which is well known to augment gastric motility. So we found at 8 weeks of treatment, they have improvement of symptoms. At 6-month follow-up, we treated only for 8 weeks. At 6-month follow-up, we can gain some cure as well as clinical improvement. So this is why knowing physiology is helpful for you to create something, some basic science, to create something therapeutically important, as Professor Premarandana already spoken. So, centrally directed therapies like behavioral psychological interventions are very, very important, and actually they are leading the way in treating children with functional GI disorders. Look at this trial which was conducted in the Netherlands. So hypnotherapy, right? Even after 5 years, there is a very clear difference between standard medical therapy and hypnotherapy. This is audio recorded guided imagery, right? It is again a mode of psychological treatment. You can see the improvement post-treat for children with functional abdominal pain. Their abdominal pain scores are clearly down. And then this is gut-directed hypnotherapy, whether delivered by an experienced person or psychologist or using a CD at home. Both are equally effective. There's no statistical difference. So centrally directed therapies are leading their way in functional GI disorders, especially for abdominal pain in children. So what are the novel therapeutic interventions? We don't know what is happening in the gastrointestinal tract. We are clueless still on basic research, but we can do something like this, electrical pacing. So fix a pacer like, you fix something for the cardiac pacing to the stomach and program it and look at the results, right? So there are pain, nausea, emesis, bloating, and symptom scores are quite down when we keep on doing gastric pacing. Sacral nerve stimulation, very similar. You can fix an electrode to the sacral nerve S234 and stimulate it, right? So this is the motility pattern of high amplitude propagatory contractions in the various part of the colon before stimulating. Look at what happened after stimulation. These forces, high amplitude propagatory contractions, as we known as migratory motor complexes, increase, so that it is expected to improve the stool frequency. But still in the early stages, some parameters have shown improvement, but some are not. So other novel therapies, regenerative therapy like intestinal neurostem cell transplantation, low FODMAP diet, fecal microbiota transplant, and personalized microbiome analysis and transplantation. These are still in their early infancy. So how are we going to help? First, ladies and gentlemen, identify they are common among children. You saw the statistics. It's so common, right? And appreciate irrespective of severity. They lead to significant psychological, social, and seriously affect their quality of life. If you don't understand these two, you are not going to help anyone, right? And pharmacological interventions have limited effects. Psychological interventions show excellent results, both in short and long term, for children with functional abdominal pain. Novel therapeutic interventions show promising results and need further refinement of the technical aspects. Thank you very much for your patient listening.